Vitamin D is a vitamin that is fat soluble and it's essential for the proper formation of both teeth and bones. It's also needed for intestinal absorption of calcium and phosphate. Now, vitamin D is going to build bones by stimulating the activity of osteoblasts. Now, on the other end of that is parathyroid hormone, which works in the opposite direction by stimulating osteoclasts, so it breaks down bones. Now, a very important relationship to remember is that whenever vitamin D is on board, it is going to stimulate calcium, it is going to stimulate phosphate. And when it does, they are going to move in the same direction. So if we increase calcium, we increase phosphate. If we decrease calcium, we decrease phosphate. Now, vitamin D is going to lead to those findings. When we're talking about parathyroid hormone, on the other hand, it's going to actually move them in the opposite direction. So if it decreases calcium in the serum, it's going to increase phosphate in the serum. Okay, so vitamin D is going to move them in the same direction, whereas PTH moves them in an opposite direction. So just keep that in mind as we move forward. Now, vitamin D can be ingested in one of two forms. It can be ingested as D2. It can be ingested as D3. And when there's adequate sun exposure, it can be synthesized from cholesterol. Now, vitamin D2 is also known as ergocalciferol. Vitamin D3 is known as cholecalciferol. So let's discuss the pathway by which we can take cholesterol and we can create a functional vitamin D. So the first step is taking something called 7-dehydrocholesterol and exposing it to ultraviolet light. When we do that, we get vitamin D3, and we just said that's known as cholecalciferol. Now that D3 can also be taken in orally, but if we want to use the ultraviolet light given by the sun, we can take 7-dehydrocholesterol and create that directly. From here, cholecalciferol is going to go into the liver and it's going to encounter an enzyme. This enzyme is known as vitamin D3 25 hydroxylase. And in the liver, that is going to create something known as calcidol, also known as 25-OH-D3. Now that was made in the liver. Now that is going to leave the liver and it's going to make its way into the kidney. In the kidney, it's going to encounter another enzyme, which is known as 25-OH-D3 1-alpha hydroxylase. Once that enzyme is encountered, it's going to create calcitrol. Calcitrol is also known as 1,25-OH2-D3. So the calcidol, the 25-OH-D3, this is the major circulatory form. The 1,25-OH2-D3, that's going to be your major active form. Now this calcitrol, this active form of vitamin D, is going to have certain effects. It's going to have effects or roles to play in the intestines. It has a role to play in the parathyroid glands. It has a role to play in bones. And it plays a role in the kidney. And now let's discuss each one of these roles individually. In the intestines, there's three things you need to keep in mind. Vitamin D is going to increase the absorption of calcium. It's going to increase the absorption of phosphorus or phosphates. And it's going to decrease the absorption of magnesium. In the bone, the role it's going to play is going to be increased mineralization. And this isn't direct, this is indirect. And the indirect increase in intestinal calcium absorption is subsequently going to lead to this increased mineralization. So we can just draw an arrow here and say that there's a relationship between these two. In the parathyroid glands, there's two things you need to remember. It's going to both decrease the synthesis of parathyroid hormone, and it's going to decrease the secretion of parathyroid hormone. And the relationship between vitamin D and the kidney is that there's going to be an autoregulation of calcitrol production through the kidney. So we're going to maintain a normal level of calcitrol. Okay, and those are four important roles that the vitamin D plays in certain areas in the body. Now, there's an important relationship between breast milk and vitamin D, and that is that vitamin D is one of the two vitamins that are not supplied in sufficient quantities within breast milk. The other is vitamin K. So vitamin D and vitamin K are not found in sufficient quantities in breast milk. Now, when it comes to vitamin K, we fix this problem because by giving an injection at birth. Now, without vitamin K, your patient would bleed excessively, which we'll discuss when we get to vitamin K. But just for now, that's what we do in order to counteract this problem. Now, vitamin D is insufficient as well. Luckily, as long as we expose a newborn to enough sunlight, which doesn't have to be a lot, they'll usually make enough vitamin D. The one problem arises when we're dealing with darker skinned individual. So if we're dealing with someone who is African American, in order to get their skin to produce enough vitamin D to keep them healthy, they have to be exposed to more sunlight, right? Because they have so much melanin in their skin that they're not going to react to a very small amount of sunlight. So they need a little bit more. Okay, so that's just one thing to keep in mind when it comes to that relationship between breast milk and vitamin D. And that's that dark-skinned individuals need a little bit more time exposed to the sun in order to produce enough of that vitamin D. So now let's talk about both a vitamin D deficiency and a vitamin D excess. Always want to know what happens when there's deficiency or when there's too much. Now, when there's a deficiency, it depends if we're dealing with children or adults. So if we're talking about children, we're going to mainly see this in the form of rickets. And what we're seeing is a vitamin D resistant rickets. And in vitamin D resistant rickets, there's a defect in the renal reabsorption of PO4. Now, remember we mentioned that vitamin D is going to move calcium and phosphate in the same direction. So if we can't reabsorb PO4, we get a drop in PO4 levels, and as a result, calcium is pulled along with it. So when you give vitamin D, you might get a small spike in increase of calcium, but that's just temporary and it's going to eventually drop off again. So what are some of the things you need to look for histologically when it comes to rickets? Well, we're going to see a very high amount of unmineralized osteoid matrix. A high amount of unmineralized osteoid matrix. We also see a widening of osteoid seams. Now remember, these are the histological findings. Clinically, you see things such as bowing of the legs, you see rachitic rosary, you see craniotabes, you see growth retardation, and you see Harrison's sulci. Now, an excess of vitamin D is actually going to cause findings that are due to the increase in calcium. And these are easy to remember. It's sort of the rhyme that we use. And it goes like this: stones, and this is in the form of calcium kidney stones. Bones. Patients develop bone pain because of the increased amount of calcium we're depositing. Moans. Moans has to do with GI pain caused by excessive calcium. Groans, this is just an overall depiction of the painful findings that we see. And the last one is psychic overtones. And what this means is that there can be mental difficulties associated with significantly increased levels of calcium.